Welcome to the deep dive. Today we're embarking on really a fascinating exploration into modern medical management. Specifically, we're looking at how some really serious infections can sometimes be treated not in a hospital bed, but, well, right at home. Our focus is a condition called infective endocarditis, or i.e. that's a severe infection of the heart's inner lining. Our mission today is to uncover the precise criteria and, I guess, the cutting-edge approaches that allow doctors to use outpatient antibiotic therapy for IE. We'll find out when it's safe, when it's absolutely not, and what it really takes to ensure top-tier care, even outside the hospital. Okay, let's dive into the material.
Precisely. And what's truly intriguing here is the delicate balance, between ensuring patient safety, making sure the treatment actually works, and just the practicalities of delivering complex care outside those traditional hospital walls. We'll examine the specific factors that enable this shift from inpatient to outpatient, the different stages of treatment patients go through, and the highly customized antibiotic plans involved. This deep dive really showcases the incredible precision and patient-centered thinking in modern medicine.
So let's imagine, maybe, a patient, let's call her Maria, diagnosed with infective endocarditis. The big question for her and her doctors would be, can she even consider getting her antibiotic treatment at home? It sounds like such a serious condition, so there must be really strict conditions. What's the first thing doctors look for when considering outpatient care, according to our sources?
That's right. The guidelines emphasize that outpatient therapy, whether it's intravenous antibiotics, that's IVs at home, what we call OPAT, outpatient parenteral antibiotic therapy, or even oral antibiotics, well, it can only be considered if the patient is clinically stable. That is the absolute cornerstone.
Okay. Clinical stability first.
Exactly. And beyond Maria's medical status, her environment and support network are also incredibly important. Her home environment needs to be supportive, ideally, with the caregiver present, and she needs to be self-reliant or capable of receiving consistent home health care. What's striking is how these non-clinical factors, like having a stable home and someone to help, are just as crucial as the medical ones in making these critical decisions.
It sounds like a delicate balance.
Yeah.
It's not just about the specific bacteria, it's about the patient's entire life situation.
Yeah.
But then, if it's such a serious condition, there must be definite situations where home care is simply not an option, where the risks are just too high. What are the absolute contraindications that immediately rule out outpatient therapy based on our sources?
Right. This is where the red flags go up. Home treatment is ruled out in several critical scenarios because the risk of serious complications just skyrockets. For instance, if Maria had heart failure or severe valvular regurgitation, which means a heart valve isn't closing properly, leading to blood flowing backward.
Yeah.
Or if she had vegetations larger than 10 millimeters. Now, vegetations are essentially clumps of bacteria and blood cells that cling to the heart valve. When they grow larger than 10 millimeters, they pose a significant risk of breaking off and causing severe problems like a stroke or blocking blood flow elsewhere.
Wow, okay, so size really matters there.
It really does. Additionally, if there's neurological involvement, like signs of a stroke or issues with kidney function, that's renal impairment, or problems absorbing medication, malabsorption, outpatient care isn't recommended. And critically, it's generally not recommended for people who inject drugs due to the very high risk of relapse and reinfection. This highlights the truly complex risk assessment doctors undertake, connecting a patient's overall health and even certain lifestyle factors directly to whether home treatment is viable.
It paints a very clear picture of who can't be treated at home. It almost feels like a medical version of, a high-stakes escape room,
Right.
where one wrong condition means you're out.
Mm-hmm.
So if a patient does qualify for outpatient management, how does the treatment journey actually unfold? Do they stay on the same treatment the whole time, or are there distinct stages or phases that our sources discuss?
Oh, there absolutely are distinct phases, yeah. And this is where the strategy of care becomes truly fascinating. The treatment is typically divided into two main periods. The first is the critical phase, which covers the initial 2 weeks. During this time, the patient is still at a higher risk, so they require very close clinical monitoring, often initially in the hospital.
Right, makes sense.
And what's insightful here is that while those IV antibiotics at home can be cautiously considered during this critical phase, it's mainly reserved for very specific, less complicated cases, like native valve endocarditis caused by certain common strep bacteria.
Okay.
Oral antibiotic therapy, however, is almost always held back. It's generally only considered for patients who have already received at least 10 days of intravenous antibiotics and are clearly showing clinical stability. This emphasizes that intense initial stabilization is absolutely, non-negotiable before thinking about home care.
So the critical phase is about intense stabilization. But once a patient clears that initial hurdle, say, and starts to show real progress, does the treatment approach change significantly? What does the continuation phase look like?
Yes, it shifts considerably. The continuation phase begins after that second week, typically once the patient is much more stable and the immediate risk of severe complications has significantly decreased. In this phase, oral antibiotic therapy becomes a much more viable option and can be used for a broader range of bacteria.
Okay, so more options open up.
Exactly. This includes common culprits like certain types of Streptococcus, Enterococcus, and Staphylococcus bacteria. The key here, though, is that even when transitioning to oral therapy, patients still need a minimum of 10 days of prior intravenous treatment and confirmed clinical stability. That means they have to have negative blood cultures, showing the infection is under control. And the doctors must confirm the absence of severe valvular dysfunction, meaning their heart valves are working well. This phased approach is all about safety and effectiveness, tailoring the treatment to the patient's progress and the specific pathogen involved.
It sounds like the details matter immensely, and the type of infection really dictates the plan. Our sources go into specific scenarios for oral therapy, native valve endocarditis, prosthetic valve endocarditis, and infections related to cardiac implantable electronic devices. Let's dig into these. What are the precise requirements for oral therapy if Maria had native valve endocarditis, NVE, meaning her own natural heart valves are infected?
Okay, for NVE, oral therapy can be considered if the patient has already completed at least 10 days of IV antibiotics or is recovering well post-surgery. So that initial intensive period is done. The infection must be caused by any agent except what are called difficult-to-treat microorganisms. These are bacteria known for being particularly aggressive or resistant.
Okay, so standard bugs, mostly.
Pretty much. It's also crucial that there are negative blood cultures at 72 hours, confirming the infection is largely cleared from the bloodstream. Furthermore, a transesophageal echocardiogram, or TOE, which is a special ultrasound of the heart taken from inside the esophagus for a very clear view, must rule out severe aortic regurgitation or other valve dysfunction. And importantly, there should be no issues with anticoagulation, meaning no problems with blood thinners.
That's incredibly specific. What about prosthetic valve endocarditis, PVE, where the heart valve is artificial? Does having an artificial valve introduce completely different considerations for Maria's treatment?
It absolutely does, yeah, and it raises the bar for caution. For PVE, Maria would also need at least 10 days of 5E antibiotics. However, the bacteria responsible for the infection must be more narrowly defined. It needs to be IE caused by certain oral streptococci, Streptococcus gallolyticus, or Enterococcus faecalis.
So fewer types of bacteria qualify there.
Exactly. There also has to be no indication for cardiac surgery, meaning her condition isn't worsening to the point of needing an operation. Just like NVE, she needs negative blood cultures at 72 hours, and that TOE must confirm the absence of severe valve dysfunction in the prosthetic valve itself. And again, no anticoagulation issues are a must. The precision here really underscores the heightened risk and complexity when a prosthetic valve is involved.
Makes sense. Higher stakes. And finally, for infections related to cardiac implantable electronic devices, CIDs, like pacemakers or defibrillators, how do those criteria differ?
For CID infections, the criteria shifts slightly again. A patient needs at least 7 days of 5E antibiotics after an uncomplicated early lead extraction. This means the infected device and its wires have been successfully removed without complications.
So the source of infection is gone.
Right. The infection can be caused by any agent except those difficult-to-treat microorganisms. There must be no pocket infection, meaning the area where the device was implanted is clean, negative blood cultures at 72 hours post-reimplantation, if a new device was put in, and a normal echocardiography to ensure the heart itself is okay. And critically, there should be no severe complications or ongoing need for complex daily care. This highlights the importance of removing the source of infection and ensuring overall stability after the procedure.
Okay, now for the really fascinating part, I think. The actual antibiotic weapons doctors deploy. Our sources provide a detailed breakdown of strategic drug combinations for different types of bacteria. It's not just one magic bullet, it's a carefully chosen team of medications. Let's start with common infections like certain staph and strep strains that are still susceptible to standard antibiotics. What are some of the key combinations they discuss for these more manageable bacteria?
Right. For those susceptible strains, the strategy often involves pairing a core antibiotic, like amoxicillin, with another agent such as rifampin or fusidic acid. The idea here is to combine a well-known antibiotic, a beta-lactam, with another drug that can help penetrate cells more effectively or, combat emerging resistance. Alternatives might include moxifloxacin or linezolid, also paired with rifampin or fusidic acid. It's all about hitting the bacteria from multiple angles, basically.
And if it's still a susceptible staph or strep, but perhaps a slightly different approach is needed, maybe based on the specific strain.
Well, in that scenario, instead of amoxicillin, doctors might opt for dicloxacillin as the core beta-lactam. This substitution is key because dicloxacillin is specifically chosen for its ability to remain stable against bacteria that produce beta-lactamase. That's an enzyme that can break down and inactivate many common antibiotics, essentially making them useless.
Ah, so it's like an armored version of the antibiotic.
Kind of, yeah. It's a tactical swap to counter a common bacterial defense mechanism.
What about when we hit resistance, specifically for staph bacteria that have become resistant to methicillin MRSA, right? That's a big problem in hospitals. What do the guidelines recommend there?
Yeah, when dealing with methicillin-resistant staph, or ConNS, the game truly changes. The sources indicate the necessity of using linezolid, often combined with fusidic acid or rifampin. This is a critical shift because these resistant strains have found ways to bypass many beta-lactam antibiotics. Linezolid is chosen for its strong ability to get inside bacterial cells and its excellent oral bioavailability, meaning it's well absorbed when taken by mouth, making it suitable for outpatient care. This really highlights how evolving resistance patterns continually force treatment guidelines to adapt. It's a constant challenge.
Absolutely. And for Enterococcus faecalis, that's another common and sometimes tricky bacteria, isn't it?
It can be. For Enterococcus faecalis, the recommendations typically include amoxicillin-based combinations with moxifloxacin, linezolid, or rifampin, and also various linezolid-based regimens. These combinations are specifically designed to overcome any intrinsic resistance that Enterococci might have and to ensure what's called bactericidal synergy. That's a fancy way of saying that the drugs work even better together, actively killing the bacteria rather than just stopping their growth.
Synergy. Got it. Moving to streptococci, what about strains that are still susceptible to penicillin? That should be more straightforward.
Generally, yes. Penicillin-susceptible streptococci are commonly treated with amoxicillin plus rifampin, moxifloxacin, or linezolid. And importantly, for patients who have beta-lactam intolerance, perhaps an allergy to penicillin-linezolid-based combinations offer excellent and very effective alternatives.
Okay. And the tougher ones, penicillin-resistant streptococci, what's the plan there?
Right, the resistant ones. Penicillin-resistant streptococci demand more potent agents. Here, we typically see linezolid and moxifloxacin, often again in combination with rifampin. These regimens are chosen for their broad-spectrum coverage and their ability to mitigate resistance, addressing the ongoing challenge of treating drug-resistant pathogens effectively. It's all about making sure the patient gets a strong, targeted response, even for the trickier infections.
What a deep dive. We've journeyed from the general qualifications for outpatient care in infective endocarditis through the precise phases of treatment, the strict criteria for different types of IE, and finally into the highly specific, tailored antibiotic regimens. It's a powerful reminder of how friendly tuned medical care can be. Just incredible detail.
It really is. If we connect this to the bigger picture, it underscores the incredible progress in patient management. It allows for high-level, complex care to be delivered outside traditional hospital walls. But, and this is the key point, only under the most stringent conditions. It's a testament to leveraging every piece of clinical data and understanding a patient's context deeply.
So what does this all mean for you, our listener? Well, next time you hear about complex medical treatments, perhaps for a friend or family member, consider the sheer volume of detailed information and careful decision-making that goes into every single choice. This deep dive shows us that outpatient doesn't mean less rigorous, not at all, but rather rigorously adapted for safety and efficacy.
And perhaps this raises an important question for you to consider. As medicine continues to advance, how will we continue to balance the benefits of sophisticated home-based care with the absolute necessity of safety and rigorous monitoring, especially as we face evolving challenges like, antibiotic resistance, something to think about.